Welcome everybody and good afternoon. Thank you for selecting this session on patient-centered care. We are delighted to be here and have the opportunity to share the knowledge gain and the lesson learned from several experience and projects our institute have been involved during the last years. My name is Carola Orrego. I am Deputy Director in Avedis Donabedian Research Institute. That is a non-profit organization linked to the Autonomous University of Barcelona. We are fully devoted to quality improvement in social and health care, covering different dimensions as patient-centered care and patient safety. And you will see that we also have another session on patient safety and perioperative care that will be led by Dr. Daniel Arnal. And for this session, that will be focused on supporting the implementation of patient-centered care in clinical settings, and specifically how to advance on patient humanization and self-management. We thought that was important also cover this dimension on self-management intervention because it's probably less developed in hospital care. So the main, I don't know, it's not working. Maybe you can put the next one, please. So the main objective for this session are, first of all, to describe and discuss the essential elements, opportunities, and challenges of implementing patient-centered care in clinical settings. This objective will be covered in the first part and the first presentation that will be given by Professor Rosa Suñol, that is the president of our institute. And then, building on an existing project, can you please put the next? No. Building on an existing and ongoing project that is a European project funded by Horizon 2020, that is Compare EU project that has as a general objective to identify, compare, and rank the most effective and cost-effective self-management interventions in adult in Europe. This project is focused on chronic condition, in particular in 4 chronic conditions. So we will develop the other 3 objectives based on the output from this project. And the second objective will be discuss and describe how to bring the patient's voice into healthcare by prioritizing topics and outcomes that are valued by them. And this is an objective that will be covered by the presentation of my colleague Marta Ballester. And then we will also present you and share with you a taxonomy of interventions and discuss about how to design a self-management intervention and the main elements to consider. And I'll present you and share with you some of the advances that we have developed, we have done on the Compare EU project for developing a taxonomy. And finally, our colleague Oliver Groen from Optimedis, that is a key partner in Compare EU project from Germany, will talk about the key strategies that organizations and individuals can use to embed self-management intervention in clinical practice. So this is more or less about this session. We, as we already described in the program, we have planned some interactive activities. So using a kind of guided process with 3 steps that will guide us about how to design a self-management intervention, starting with prioritizing and defining the target audience, then defining the objectives and the outcomes, and then selecting and adapting the interventions. So I hope you enjoy the session. And if you have any question, you have the apps to include your question also for those that are connected from home. Okay, so Rosa, it's your turn.
Let me try. Oops. I'm trying to do it. No. Well, good afternoon to you all. Thank you for being here with us. This first part of the presentation, we thought that it would be important to have a common understanding in what is patient-centered care and what are the different parts that it's made of. The reason for that is that though person-centered care was a concept that was introduced by Carl Rogers at the beginning of the 60s of the other century. He was a psychologist who had an approach of changing his approach about patient care. So he developed a system called person-centered care. After that, we have a lot of us, I think most of the people that are here, and patient organizations, professionals have developed a lot of knowledge, a body of knowledge on patient-centered care, but still the pieces don't fit very well. So what happens is that there are different frameworks, different ways to nominate things, and what I'm trying to do now is to try to put together a common understanding of what we are going to, the concepts we are going to use in this workshop. Patient-centered care was one of the dimensions suggested by the Institute of Medicine when they developed their own the paper in 2001, Crossing the Quality Chasm, together with patient safety, effectiveness, cost-effectiveness, accessibility. So it was stated that patient-centered care is one of the dimensions of quality. And it was defined as the care that respects and responds to the preferences of patients. So what it was building this concept is that the paradigm is changing, and what we are trying to do from the healthcare, that I'm talking about the 2001, so 20 years ago, what we will define to do at in this approach is to put person in the center and try to work according his or her preferences and needs. To do that needs a collaboration among patients, families, and professionals. So it's not the professional saying what you have to do, but a collaboration and a common understanding, and also ensuring that the patients and the families have the enough knowledge and education to be able to manage their care. This is 2001. Then a lot of frameworks appear about what is patient-centered care. And one of the most popular, I'm sure you know them, it's the framework of the Health Foundation. And it says there are 4 dimensions based on the patient-centered care, which are care is personalized. Let me see if I'm able to ping on that. I'm not able to do it, so it probably doesn't work. Care is personalized. It's enabling. It means enables patients to take their own decisions, to take their own decisions and act actively in their care, and it's a coordinated care and overall, it's care that treats persons with dignity, compassion, and respect. I think these are concepts that were not normal 20 years ago, and now what is introducing is part of the professional life to introduce this type of care, which is based on dignity, respect, and compassion. Today, of course, we cannot cover everything. Today, I would like to discuss with you something about what is in Spain called humanization. That could be the personalized care, the idea of care directed to the personal, but mainly we will devote this session to enable patients, patient empowerment. So this is what we're trying to cover at this stage. Well, personalized care is the care that puts us in a challenge to do what really patients feel and need, and who brings to the patients the most important for them. And the most important could be visits that are not for a person, could be for a beloved one, that could be a dog, or could be another thing. It's just to demonstrate that personalized care is something that, as it says, is personal. So it has to be adapted to each person and person needs. I'm sure you all have done a lot of projects on that field, so I'm not explaining you new things on that, but just to remind you some of that, an important instrument for that is this issue of what matters to me, what is important for everybody, or everyone at the hospital or at the primary healthcare level. For some people, important things is to be alone and without anybody. For others, is having visits, whatever. What is important for you? Of course, addressing multiculturalism. Most of you have worked about customized menus, but probably not so much about self-medication. If you are in a hospital and you can do it, why don't you take your medication? things that said, that changed the paradigm a little bit, no? And this is just to throw you some ideas about the personalized possibilities of projects. I would like to also stress this one, that's using the healing power of a patient's history. That's very important for the ones working in primary health care and long-term care. If you know patient's history, patient's belief, what matters to them, being personalized is easier than if you just treat the person as a person that stays there and that's it. And what we have brought to you as an example is a project that perhaps could be interesting for you. It's a project whose name was Miremos. Let's look at in English. And the purpose was to work together the 7 children's hospitals monographic in Spain, all over Spain, to enhance the approach of emotional well-being for children. So how can we do that in helping to enhance the emotional well-being for children? I'm sure some of you perhaps are from Hospital Sant Joan de Déu. You have been also working on that. You could also be here explaining that. But it was an interesting process. The project that was, I was saying, it was the seven children's hospitals, the important children's hospitals in Spain, all over Spain, and they worked together in a collaborative project to enhance emotional well-being. The project was quite complex. I'm not going to explain everything, but I would like to stress on this area. It's the work they have done, they did before, they decided what will be the topics they were going to cover. Well, we wanted to support emotional well-being, but how can we do that? And then, using the paradigm that you cannot do anything for patients without patients, they say, let's ask the kids and the families. So they start making interviews and focus groups and visits to the kids, and they record what they call patients' views, patients' statements, and then bring these statements to the professionals and said, what can we do to help that, to solve that? I brought here to you some of these statements. For example, the professionals shouldn't be so fast. They just come to my bed and blah, 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 and they leave. Or things like, they don't tell me the facts, the true facts. And no matter how much they avoid them, they are facts. So this is what the kids are saying for the professionals. So there was very deep input. I like the smiles that the staff give to me. Seeing my mom sad makes me sad as well. So these issues that were important to just record that and collect these children's voices to help professionals to decide what to do. But these were, I think, even more touching. I'm sad because my legs were ugly and the psychologist spoke with me and gave me a medicine to make me feel better. Feel better because I was sad. Or I feel embarrassed when they underdress me in the operating room. Or at the intensive care unit, there were sick children and sometimes you saw them dying. And I'm talking about kids of 8, 9, 10 years saying this type of things. And also interesting and nice things like I like the hospital schools. I make me feel normal. Or my ideal hospital is one that have a beds that give you a massage. So what we did is we just confront the professionals in these hospitals with these ideas of the children, and the professionals start putting order and how can we improve these feelings for the kids. And then we say, well, and that was the final of almost 200 professionals saying, well, we can increase family support, we can improve professional relation, we can improve in communication, we can address end of life more than we are doing, because all these hospitals were doing that, of course. And then they will be able at the end to establish 5 goals for improving altogether. And that were the 5 goals. That is, we wanted to increase assessment and emotional support by a multidisciplinary team at least once a day, through the hospitals. We can enhance information and communication. We will have parents all everywhere, in the anesthesia, in the intensive care units. I have to say that it weren't everywhere, though we thought they were. We will support the pain assessment in the small procedures we have, and we will work on coordination and in coordination of care. That was the way that the topics were established. I have to say, I'm not going to present the results. I just wanted to made you go through the process of how a humanization process needs to be relying on kids, families, elderly people, people going to die. You always can ask if you are a careful way to do it. So please remember that humanization or personalization has to say nothing with us, nothing with us. So we have to be there, patients have to be there in the decisions we take. And now, let me move to patient empowerment. What is patient empowerment? What are the concepts besides patient empowerment, and what are the concepts we are going to use in this workshop now? We said patient-centered care includes enabling patient empowerment, and the key word for patient empowerment is activation. We want patients to be an active member of the team. And this is patient empowerment, to achieve patient activation that will bring us to shared decision-making, to self-management. So the key word is how we make patients being active in their condition, in their role. And for doing that, we should know that health literacy is a key element. Health literacy is the capacity of a person, patient in this case, to seek for the information, understand it, and use it for making decisions. Remember, at least half of the patients we have didn't understand us at all. Didn't understand our words. They don't understand how to manage what we are telling to them. So it's very important that we are going to work with vulnerable patients. Health literacy is a key cornerstone that will allow us to go to shared decision-making and self-management. As I told you, the key work is trying to get patients activated to have an important role on their care. And what is self-management? Self-management is defined of what individuals do, or the communities, but the individuals do, to promote, maintain, and restore their health. So it's what do you do for yourself? Okay? And with the support of the professionals or without it, with the support of other patients or the family. Okay? Self-management could be something that is horizontal, but it always needs support. It is support that self-management needs. It's called self-management interventions. Are the projects you are supposed to develop one today to support self-management in your patients. And these projects could be, I don't know, you will see in a few minutes, could be reminders, could be emotional support. This intervention is what supports self-management. Okay? And why self-management is important, just to finish this work? Well, first of all, because self-management is crucial in chronic conditions. You know that over 80% of people in Europe over 65 have chronic conditions, and a lot of money, I think it's 7 to 80% of health cost, is devoted to treat chronic care. So this is extremely important. You will see now some economic consequences of that. So self-management is important because when it's addressed to chronic condition, it can make huge differences. What type of difference? First of all, it can improve clinical care and clinical outcomes. Not always, but most of the time, self-management improves clinical outcomes. even some articles exist saying that when it's conditional self-management are better managed than were managed by professionals. So and I think it's not strange because patients are with themselves all the time of their life and the professionals just enter there few hours a year. So if they care by themselves, it could really work. But also it's important because it changes the paradigm. It makes a difference between what the patients are doing and what have done later on. And just to finalize, because economically is important, self-management. Because if you just provide 25% of formal care, the other is provided by patients with informal care, if you decrease that 1 or 2%, the consequences economical are very important if patients take care of themselves. So this is also important consequences. And also there is a big business, big markets in Europe about supporting apps and self-management support. So I think this is just to convince you, I'm sure that if you have come here, you are already convinced, to draw this project of self-management ahead. And now is your turn. We hope you will be able to develop your self-management project. You are supposed to go to menti.com or look at this QR, okay? And answer the question, what will be my target population? You can do that by yourself or with the person you have besides you. So let me see. Here it is. Let me just go here, okay? The question is, what is your target population? Who are you going to address your intervention? Are you talking about diabetic patients? Are you talking with children? Are you going to elderly persons coming to your hospital? Who is your target population in your project? You will need to work with them all the process. Okay, just remain on that. Pre-operative, okay. Hospital users, child. Marta, would you take the floor?
Perfect. So we could see that you had a lot of different target audiences. You are thinking, and it's nice to see that you are already thinking not only on the disease, but you are also thinking on where you will be working with these target audiences. We could see also some of you were thinking of specific socioeconomic characteristics, like people that have migrated or younger people, etc. So keep in mind this, and we will come back to this in the next exercise, okay? Now that Rosa has presented a little bit about self-management, today I want to continue presenting, okay, if we decide to work with self-management, what sort of goal can we achieve? What can be the things that we can strive towards? Let's say, like, how can we focus on what is more important? Rosa, when she was presenting the self-management intervention, she already introduced that there are some components to self-management that are sort of the basis. And when we think about the goals of self-management intervention, a lot of times we will find that we have a sort of a chain of the outcomes, right? Maybe our first outcome in a self-management intervention is going to be to empower the patient, to just make the patient feel more empowered, and that's our end goal. That would be fantastic already in itself. But then maybe we can say, okay, I want to empower a patient so that he or she can also self-manage better, right? I want to empower a diabetic patient to maybe monitor better their blood glucose. That would be great as well. But usually, we also have another end goal in mind, right? We are doing that because we think that in this way we can improve their clinical outcomes. Or maybe in this way we can improve his or her quality of life. Or maybe we can improve the perception of care of this person on how we are treating them. Or maybe we can reduce the costs of the care, or we can achieve a better cost-effectiveness balance in how we are working with this person, right? So of course, when you start thinking about all this chain of outcomes and all these possibilities, it's clear that we can have a challenge in that we have a lot of potential outcomes, and therefore the research to inform us in how to choose an intervention can be challenging as well, because it reports on thousands of different challenges. And if I'm a manager of a hospital, how do I choose what intervention is better? Because the information is very fragmented, right? I'm sure you have come across this sort of challenge. Luckily, there's some initiatives in research that can help us to get more information and to produce information from the research community that is more usable for other stakeholders, including managers, but also patients and other stakeholders. And here are the core outcome sets. The core outcome sets are basically an agreement where researchers say, okay, from now on, when we do research on this topic, we are all going to agree on at least measuring a common set of outcomes, so that then the other stakeholders are going to be able to use our research. Because if we all measure quality of life, we can know which of our interventions is better to improve quality of life, and maybe other outcomes as well, but at least we have a basic set of outcomes that we can compare across, right? This is very interesting, but of course, if today we are talking about patient-centered care, when we are designing which set of outcomes we have to choose, it's crucial that we involve also patients in saying what are the most important outcomes for a type of intervention, right? Otherwise, we would be repeating our tendencies of asking just to the patient in the last stage of the whole process. No. Let's involve them. Let's ask them from the beginning. Where should we be working on? In healthcare, from research to management to delivery of care. In our research, we have tried to apply this to ourselves, and we have developed a set of core outcome sets for 4 diseases that we are working in our project. In our case, we are working with 4 chronic diseases, and just very briefly, the methodology that we used was to first, of course, review what has been already done in the literature, where there's sort of evidence there is for self-management interventions for these 4 chronic conditions, and then we did a Delphi process with patients to tell them, okay, from all the potential outcomes that we find in the literature, which ones are most important for you? And then we had a nice workshop as well and a discussion between the preferences of patients, but also other stakeholders. We involved researchers, but also managers and policymakers to try and fit all the key outcomes that are relevant for all the stakeholders involved in healthcare. And today I'm going to present you some of the basic results of this process. Now, first of all, you can see here, we have still a long list of outcomes, and you can see we have 4 columns for the 4 diseases. And I'm going to just highlight you some of the topics. First of all, because we were speaking about self-management interventions, of course, all the patients in the 4 diseases thought that it was important that those interventions actually improve empowerment. This seems pretty logical, but we would be surprised. Sometimes self-management interventions fail, they are not successful in improving empowerment. So first of all, let's make sure that we are actually empowering patients when we do design an intervention of this sort, right? The second, you can see also in the 4 diseases with variations, but all of them also agreed that it's important to make sure that we are improving the adherence of the self-management behaviors, right? You remember the chain? We make a patient empowered, they can improve their behaviors that are expected from them in self-management, and then we expect to also get other results. Regarding clinical related outcomes, of course, those are very disease specific, and in each disease, you can see they highlighted some that were crucial. I want to just stop 1 second now and highlight weight management. For obese patients, they told us, this is not our priority. We are sick and tired of always being measured against whether we manage to lose weight or not. And that's fine, we realize that's important, but my life is not only about that. While I lose weight, I also want to have a better quality of life. I want to be able to sleep. I want to have a nice sex life. I want to have so many things, and not everything is about weight. So if I'm going to be a chronic obese patient fighting with obesity for 40 years, please don't only measure weight loss. Other things are also important for me, and we always want to highlight this. Of course, when we do research, we include this as a key clinical outcome, but it can't be the only clinical outcome that we measure, the only outcome important for patients. There were also other sets of outcomes that were highlighted by patients. You can see quality of life was important for all of them. You can see sometimes articulated in different ways. I want to highlight that a lot of times, especially for patients with COPD, heart failure, and obesity, they were telling us, yeah, the general measures of quality of life are very nice, but we want something more specific. So for example, in COPD, they were very specific about, we want to improve sleep quality, we want to improve our sex life as well. No one's doing research on sex, and that's important to us as well. And we want to improve our capacity to socialize, for example, right? So not only the generic quality of life, but actually how it impacts on my daily living, of course. Then you can also see that all of them wanted to be involved in participation and decision-making, so this was an outcome that they wanted us to include always in research for self-management. But also you can see that they are also concerned about the number of visits and the use of healthcare that they make, and they articulate it in different ways, but the patients are our allies. A lot of times, if we want to make our system more cost-effective, patients are allies. They are, in many cases, the first ones interested in not having to come to primary care or to the hospital 25 times a month. If I can manage well and I can be well coming less times, or maybe with some virtual contact in between, I will be happier and it's more cost effective. So maybe here we are finding ways in which it's beneficial for the whole system and the individual patient. Now, we didn't stop here. We did discuss, and we hope this is useful for future research to actually be focused on what's important to patients, but we also analyzed the literature on self-management interventions, and we are now able to report, okay, how much research is being done for these outcomes that are important to patients. And now you can see in the results, you can see in a color scale where red is very little research is being done and green is a bit more research is being done. As you can see, unfortunately, there's a lot of red still. So we, as a research community, we still have work to do here. To highlight some things, for example, experience of care was very important to patients, normal, but you can see everything is red. Very little research is done in actually including perception of care within the outcomes that they measure. Quality of life is a bit better. A significant percentage of RCTs, of clinical trials, do already include quality of life, but you can see that, for example, in diabetes, it's 26%, so it's not like still a majority of studies included. If you see in another set of outcomes, especially clinical outcomes, one could imagine that clinical outcomes would be all green, right? That we would all have a common set of clinical outcomes that we measure. You can see that not. For example, measures of sleep quality linked to COPD with breathlessness are very seldomly researched. Or long-term complications in diabetes are very seldomly researched as well. So here, even for clinical outcomes that are important for patients, we don't have enough evidence yet. We cannot provide the evidence to the healthcare system if we don't do research for the outcomes that are important for everyone. Now, I hope you found this interesting, and now we would pass it back to you and think, okay, you were thinking about a target population before, and now we would ask you to just think a minute and say, okay, if I would be working with this target population, what outcomes do you think would be the most important, the most significant for them to improve? As we did before, you go to the same website, and if we can now activate the second question, you will see the possibility to include the top 3 outcomes that you think would be most relevant for the patients that you were thinking about. You're going to give a couple minutes, because sure, you have to think a little bit about which outcomes. I see we already have some contributions. Just going to give a minute for you to send your contributions, and now we can see how it comes. Very good. So we can see already that autonomy is one of the key concepts that you are highlighting, together with, we could say, with empowerment. They go hand in hand in different ways. Return to normal life. You have seen that that was very important to many patients across all the diseases. Nice, I see that someone is also including pain. That depends on the disease, of course, is extremely relevant to patients. It wasn't maybe not so highlighted in our chronic diseases, but depending on your target population, it can be. And you can see the variety. You can see already here with, let me check. With 25 contributions, you can see already we have this universe of potential outcomes and how disaggregated they are. So what we hope that can be useful is this set of core outcome sets as something that we can always come back to and check, okay, these are the basic outcomes, especially if they have been developed with the input of stakeholders, patients centrally, but also managers and other stakeholders in the healthcare chain. And then as a research community, we also have this lesson due to have better research so that we can actually provide the information to other stakeholders so that they can actually choose what's the intervention that's more effective for the outcomes that are most important for your stakeholders, for the patients you're dealing with and your stakeholders in your context. We hope you found this interesting.
Okay, so now we are going to the third part of this session that is about designing the intervention to improve patient empowerment and self-management. As Dr. Suñol already described, when we talk about self-management intervention, we are referring to those intervention or project that you put in place aim to equip patients and their informal caregiver, whenever appropriate, to actively participate in the management of their chronic condition, but also other conditions. So in the context of our Compare-EU project, as we mentioned, we needed to identify what were the most promising self-management intervention for these 4 diseases. And we thought that was very important to have a common language to talk about patient empowerment. So we thought that was important to start with a taxonomy. And what we did, is already published, was to develop and externally validate a comprehensive taxonomy for self-management interventions. So this is focused on chronic condition, but I insist that most of the components are also valid for other type of diseases. So we use a mixed approach, starting with a literature review, including systematic review, including also other taxonomies that had been previously developed. We use concept mapping and identify the critical attributes of self-management intervention, and we prepare a draft taxonomy, including several components, and this taxonomy was sent to a group of international experts using an online Delphi procedure with 2 rounds. And with this, after this process, we had a final taxonomy, a refined taxonomy that included 132 components, 4 domains, 25 subdomain, and 103 elements. So these are the 4 main domains. You already have worked on the target population and the target audience. So you already defined the target depending on the intervention recipient, even if they are caregiver or patient, or if you select depending on the disease characteristic, maybe you want only to focus on patients that are more severe or patients that have low health literacy or have a socioeconomic disadvantage socioeconomically. And Marta also talked about the type of outcomes that we want to improve. So we also need to consider what kind of behaviors we want them to change or improve. So there are also a classification presented here about the expected behaviors. Maybe you may want to focus on lifestyle behaviors, or maybe some specific behaviors related with the disease that we call as clinical management, or maybe you want to improve how they are coping with their disease. So we need to improve their psychological skills or their social management, and even they need to skills to know how to communicate better with healthcare professionals. And then we have the components of the interventions that I will detail a bit more. So the first component on when we consider define an intervention, and this is not only for research, it's very important for designing your intervention because there are a lot of improvisation in healthcare. So we need to use a systematic approach. So the first is, okay, let's to define what are the most appropriate support technique. And when we talk about support technique, we are referring about those methods that are used to provide care and encourage patients with chronic illness or other diseases to help them to understand the role they have to play. And this technique can include sharing information and more classical, maybe this is what we are most used to provide leaflet, to provide information in the website, but also other type of support as, for example, the importance of self-monitoring and how to feedback patient on this self-monitoring process, or increasing their skills training on a specific procedure, or, for example, providing some equipment that is widely used for lifestyle intervention. On even a more advanced, we would like to say that it's a more advanced, but it's about sharing decision with patients and using patient decision aid to make decision together about important and relevant treatment decisions, for example, on their care. That is also a way to improve self-management, or preparing an action plan or specifying goals that you expect or you can decide together with patient about what kind of outcomes are expected for them to self-care. Because it's important, we always say to our students in our master degree that we need to be aware that patients are most of the time are alone. It's calculated that a diabetes patient is more than 95% of the time caring for themselves. So they need to learn about and have very clear what they need to behave and how to behave. And we can also use other techniques as, for example, coaching patient or using motivational interview and other, let's say, more advanced process, or even some social support activities, learning from peers, exchanging information, lesson learned with others that have the similar condition to you. So this is about support technique. It's also important even more in this context of the COVID situation, which kind of delivery method you will use, which kind of resources you have, and for that, defining if you are going to prepare or to implement this as in a face-to-face or using remote techniques, and for that, maybe you need to use the telephone because it's also, there are also evidence that older patients prefer, if we use remote intervention, they prefer to call or be called by telephone than using a smartphone or a video or a web-based intervention. So it's also important. And of course, deciding what kind of recipient. And with recipient, we mean if we want to perform this intervention at population level, mainly used for some public health campaigns to make people more aware about some behaviors, or if we want or prefer to implement this intervention individually, or if we think that this social support can benefit the target population we previously defined and the objectives we previously defined using groups. And of course, we need to decide which kind of providers will be involved, and not necessarily this include only healthcare professionals. We can also have other type of professionals, social worker, lay person from the community that after reviewing thousands of papers in ComparEU, we have learned that there are a lot of initiatives that are well described and with good results, given evidence on the importance of layperson, and also intervention that are implemented by peers, peer support, other people that even is more expert than us to explain, to help patient about how to self-care. And of course, we need to decide the location. Sometimes the hospital is not the best place, and sometimes yes, because maybe if we cover a wide range of population, we may prefer to organize sessions in the hospital or go to the community, and even more now that integrated care is something that is very important. And that's it about the interventions. And of course, in any complex intervention, as also self-management intervention, it's very important to consider the context. So when you have a target audience and you have a specific group as objective and you have a list of interventions, you need to see what are the context, what is the context where I am implementing this intervention. And for that, there are a lot of literature. We are also reviewing this contextual factor in compare review, and we have identified some common contextual factors as patient-related contextual factors of, for example, the motivation, patient motivation, the patient burden with the disease, with the behaviors, patient characteristics, what is the level of health literacy, the barriers, cultural barriers, or the social support the patient have to implement these behaviors, or providers contextual factors that are more related with the knowledge, with the social demographic factors, which are these characteristics, how they are convinced on this type of intervention, and of course resources from the organization, education, capacities, capacity of collaboration with other organizations to improve self-management intervention, and for sure how the patient-provider relationship is. So this is about this self-management intervention and how to design and how to define the component. This is just an example from a paper. You know that in this compare review project we included randomized control trials, and we included hundreds of randomized control trials for self-management intervention published in several journals. And this is just an example where to show you how in this case it was an intervention that was 1 hour of education using guidelines, the gold guideline for COPD, and they share information, they use face-to-face. They also observe how the patient use the inhaler. They included as a expected behavior smoking cessation, recommendation regarding vaccination, instruction about hand hygiene, for example. They also use action planning, so they prepare a specific plan for patient about what will be the steps and the process to self-care. And they also included an individual approach, and they use a telephone calls for follow-up and to remind patients and follow up also about some questions and some barriers and how to approach them. So, and also there are some contextual factors that are described in this kind of intervention. This is more or less what we also expect to do when we design an intervention within an organization. And now we can go to the third step of this pathway about selecting and adapting intervention. We want you to think about what would be the most appropriate intervention, considering your local priorities and the objectives and the target audience you already have decided. And you can say, okay, this is the intervention I would like to use, considering, of course, the contextual factor you have, the resources, the capacities, the professional knowledge, and so on. So go to menti.com. Also the people that is at home. So you can think about the type of support. I don't know, you are able to see the screen, the provider. You may need more time to write, but just think about what kind of support you would like to implement. I don't think. If you can move the mouse, because I think the note is. Okay, now. Thank you. Okay, so reliable literacy, listening, shared decision making. I see that 2 shared decision making, face-to-face intervention, coaching, patient follow-up and care, using groups and individual, education, healthcare professionals, very important. Using motivational entertainment group, this is very nice. Skill training in face-to-face. Change management, I can imagine that you are referring also to within the organization, you need change management also for improve and implement this type of intervention. Focus groups, working on health literacy, involving professionals. There are a lot of nice ideas, individualized care plans. So thank you very much, and now the turn for Oliver.
Thanks, Carola. Before I forget. So we've heard now about the motivation, why it's important to think about humanization of care, patient-centered care, and patient empowerment. We've seen a taxonomy to describe the range of interventions and settings and context factors that are associated with self-management, and we've talked about outcome measures. What are outcome measures for self-management interventions? And you've seen they're very variable, very broad, and patients might bring very different ideas about outcomes to the table than clinicians or managers or researchers. So for this last bit, to close the circle now and look at the implementation of self-management, I've chosen the title, What do we know about the adoption of innovations in routine clinical settings? And that is also a piece of work we're doing in the context of the CompareU project. It's also a research project we have done 2 years ago in Germany, and it started with a very simple idea. In Germany, we know there's a scarcity of self-management interventions, so we did a study to test the extent to which self-management interventions are actually implemented in routine care settings. And our idea was very simple, because we thought, okay, there's a shortage, there's a gap, and we simply want to know what is the most appropriate timing to introduce self-management. Because you might have a patient who goes to the GP, who goes to the specialist, who goes to the hospital, who goes back to the specialist, who goes to get separate tests done. And at the same time, during the pathway, a new diagnosis emerges or different lab results emerge, which trigger the relevance of certain self-management interventions. And we thought that we would be able, by conducting interviews with 20 doctors and 20 patients, to identify the optimal point in the clinical care pathway to trigger the self-management intervention. So obviously, after a diagnosis or before a major intervention. But during these interviews, we found out that it's so much more complex to introduce a self-management intervention into the complex organization of a hospital or the healthcare system. So I consider self-management interventions now innovations, just as technological innovations, and they are here defined as a novel set of behaviors, routines, ways of working that are directed at improving health outcomes, efficiency, cost effectiveness, user experience, and that are implemented by planned and coordinated actions. The definition already addresses the breadth of self-management, as we've also seen in the taxonomy. And when you look at the literature on the implementation of innovations in general and self-management in particular in routine clinical practice, you see there's not an easy way. And the literature shows that innovations are insufficiently adapted in routine clinical settings. Now, one of the key authors to look at the transfusion of innovations is Professor Greenhalgh, and she looked at a wide range of literature with the aim, in a realist review, to identify theories of implementation. And that's quite interesting, because a lot of the research published reflects a theory of make it happen, which means there's new evidence, there's a manager says we're doing that, there are professionals that support that, and it's done. Now that's a very linear reductionist perspective on implementation. But there's also a lot of literature, particularly on the shortcomings of the implementation, that suggests, well, there are different theories. There's a theory, for example, to help make it happen or just let it happen. Let's just see, put in an innovation in the setting or bring in the information and see what happens. And the interesting thing is, if you look at the defining features on the make it happen side, the linear reductionist side, we have a scientific approach, like a tailorist managerial approach, where we plan, regulate, program, and then just manage it. And on the other hand, that's more the social sciencey side, the negotiated order side of things. We have a complex intervention which is unpredictable, unprogrammed, uncertain, emergent, and the system is self-organizing to actually adopt part of the intervention, or all of it, or nothing. And also the metaphors for spreading the interventions are very different. On the linear side, we have re-engineering, we re-engineer the system, and on the other hand, we have issues of complex theories, complex systems, emergence, and knowledge constructions. So I argue, and that's also a role that we have embedded in the CompARE project, that we need to have a business plan to bring this evidence into practice. We can't just assume it's being translated into clinical practice by the same mechanisms that we have for pills or health technologies, which is via guidelines or clinical decision support system and similar. So we need to have a business plan. And nothing is more practical than a good theory. And we have used a theory by Darmschroeder on the implementation research, a theory that has become very well known 10 years ago to look much stronger at the implementation factors that might hinder or facilitate the implementation of an intervention. And the different dimensions or domains of this framework are called intervention characteristics, which is basically describing the self-management intervention, the outer setting, which is if we're working in the hospital, it's everything around the hospital. It might be other care providers, it might be the health system. The inner setting, this is our hospital or health service. Characteristics of individuals, this is us, our teams, our colleagues. And finally, the process. And I've now, to wrap up this session, produced a couple of prompts for each of these domains of the framework that would help us reflect on how we can actually bring our self-management intervention into the clinical context. So first we have the intervention characteristics. And here, as I said, on the right side, some possible themes to develop a business plan. All these are just prompts or themes and need to be developed further. But the first thing is, if we look at the results of the CompARE project and a lot of the research that was mentioned, the RCT, we know that the RCT evidence ideally gives us a pooled estimate of some sort. Often we know the literature is heterogeneous. What do we do with that? So from an implementation research perspective, of course, the strength of the evidence is very important. The stronger the evidence, the more likely the uptake. But it's more complicated than that. We also need to have cost effectiveness, especially if we want to convince organizations or managers. And when you talk about cost effectiveness, you find a lot of cost effectiveness studies with a time horizon, 25 years or a lifetime perspective. That's great if you want to inform a ministry that has a long forward view, but a time horizon of 25 years is not really useful to convince a manager who has to look at the next quarterly numbers or the income of next year. So that is already a major limitation if we look at evidence. Secondly, complexity. It would be so nice if we could just have the self-management pill. You know, we just give it to every patient. But self-management interventions are very complex, as we have seen in the taxonomy. And the more complex the intervention, the more difficult it is to adapt it. And you need to think, okay, which of these factors I can embed in my system and which factors are actually not applicable, and what does that mean? I need to overhaul the whole healthcare system. That's not possible. And secondly, I alluded to that a moment ago already, the adaptability. Is the self-management intervention actually adaptable, or adaptable to my context? What was the comparative group in the study, or does it require a certain skill mix that I don't have in my health service? Next one is the outer setting, and that's the obvious one. It's very easy to follow this argument. If we look at the health system context, the question is there actually any incentive in the healthcare system to reward, incentivize the implementation of self-management? If we pay GPs by fee-for-service, if we pay hospitals by DRGs, why would they be bothered? Why would these organizations be bothered to adopt self-management interventions, which often only generate an impact over a long period of time? There might be ways of looking at complications or readmissions, but still that's a shorter time horizon. Does the country or region's health system performance assessment model take into account SMEs? So if you are counting in your healthcare system the number of beds, the number of nurses, the number of doctors, then the answer is no. But if you have a healthcare system, like in some countries where you actually collect PROMs or PREMs, the answer might be yes, because SMEs might have an effect on that. So the healthcare system monitoring or performance assessment context has some leverage on that. I've mentioned the reimbursement model already, and there's also an understanding of do you see yourself or your team or your organization as the most appropriate place? Hospitals are often not seen as the most appropriate place for self-management interventions. That is changing, and there might be many diagnoses where it actually has a big effect, and the timing would be appropriate to introduce a self-management intervention. The third out of 5 themes is the inner setting. And again, that's very logical. That's within our health service or hospital. Is the introduction of the self-management interventions appropriate in the context of patient needs? So if you go to an intensive care unit, obviously there's an urgent patient need, urgent monitoring, keeping the patient alive, and discharging the patient to the ward. That's the patient need. So that's an exaggeration. But even on the ward, you might say, well, I just want to stabilize the patient, and then I can discharge him or her to primary care, and let the GP deal with that. So the question is, which is the appropriate setting for the intervention given urgent patient needs? And that is what was also something that became very apparent in the context of the pandemic, when we discussed self-management interventions with our doctors in our networks in Germany in the last 1.5 years. It wasn't an urgent patient need. You had a lot of patients with urgent or acute COVID symptoms, or you had to vaccinate. So self-management interventions were often not seen as an urgent patient need. Secondly, does the whole notion of humanizing care actually resonate with the culture of your organization? If your mission is, we're providing the best high technology, gene therapy, enhanced care for our patients, and if there's no mentioning of the word patient care, patient-centeredness, humanization, then it might reflect that the values do not align with the organization's mission. So that's very important. And then, actually, do you have the task roles in your team? Who would be the best amongst the professionals, the best team member to take charge or to take the lead in most of the self-management interventions? If you think about counseling, emotional support, social support, who should do that? Do you have the team members? And then the final setting is the characteristics of the individuals. That's you, me, us, our team. Does a team actually support the self-management intervention? Do they believe in the benefit? Does it resonate with their view of the urgent patient need? And is there perhaps a training need? Do we need to perhaps train our professionals on communication skills, on patient education, on motivational interviewing or counseling? Do we have those skills in the team? And finally, our patients. we've heard the issue of health literacy before. That's a topic in many healthcare systems, many patients. Are our patients actually prepared to a level that they are open to these ideas, that they can comprehend the different tasks and the different actions that they can take care of, and at what point of time can we identify those patients? And that brings me back to the opening, because that was, in the other research project, our idea. We just identify the appropriate time, and then, once we have identified that, just implement the self-management interventions. But I think you've seen from these 5 slides, with the 5 domains of the implementation of science framework, it is rather complex. So what do we do from here? Oh, sorry, I forgot the process. The process is very important. But that's the point I just mentioned a moment ago. At what point in time do clinicians need to be informed, or the SME to be triggered? And that is also a question of information technology processes. Because similar to clinical guidelines, which are embedded in clinical decision support systems, we could potentially embed self-management in evidence into clinical support systems and trigger at the right amount a patient decision aid, information about the relevance of a chronic disease and how to live with that, and provide it to the patient and the professional in an easy manner, so that it's not all work for the professional to look at those patient decision aids or evidence if the professional, the doctor, the nurse believes they want to pass on this information to their patients. And the final point is the alignment of organizational priorities with the SME outcomes. Does your organization actually monitor the implementation of self-management? Again, if you're only counting the turnover, the number of patients discharged, the number of patients admitted, the number of surgical procedures, then this will not get any kind of visibility. But again, if you are counting, if you are actually registering in your records the self-management needs of your patients, whether they need counseling, education for smoking, alcohol or other substance abuse, and then also document whether they have been provided such information, and even maybe asking the patients whether they understood or follow through these interventions, then your organization will support the embedding, the implementation of self-management evidence. So these were the domains of the implementation research framework, and the summary from that is we need to look at it more like not so much like professionals, but more like managers, and develop a business plan that captures the complexity and brings it down to simple solutions. Because in the commercial world is as complex as the non-commercial world, but the commercial world is very successful in reducing the complexity and sell a certain product or service. And I think we should use that knowledge to sell something good, which is self-management. And we then need to demonstrate that we can align, or that these self-management interventions are aligned with the healthcare context factors, that we can reduce the complexity and bring it into organizational focus. And of course, there's no one size fits all. This needs to be adapted to many different contexts. It will be different in Spain than in Germany, than in the UK, and it will be different in hospitals or primary care centers. So these would be my observations. And I guess now we have time for questions. And of course, questions to all of us, not just to me. We have time left. And I would take your questions, and please just say whom you want to address your question to, and then either of us will respond to your question. Maybe we can even get a little bit of a discussion going, whether you believe that is actually the exercise is helpful, or whether you believe that is over complex, or there's actually a much easier solution that we are not aware of. Thank you.
Can you hear me? Is this okay? Well, while someone maybe thinks about a question, we had a comment online. It's more a comment than a question, but I think it's nice to get the conversation going. Someone wrote that they are a geriatrician and they agree that patient-centered care is crucial for the most complex chronic patients, but also in their context for oldest and frail patients. Asking, listening, and making what matters most for them is more complex even than just for chronic patients. So I think here the colleague is opening the conversation to how we handle people with multiple demands, not only chronicity, but also frailty, older age, and maybe we can share some reflections from our project.
Yeah, well, I just wanted, I completely agree. I think the people working in long-term care and geriatric care have teach all of us how to address this issue. Most of the systems I mentioned, what matters to you, for example, were developed for this type of patients concretely, because these are persons, whether their beliefs or their needs are even more important than their clinical condition. So I think it's quite relevant to see that in these cases, where you are confronted with a vulnerable person, a social complex person, or a very clinical complex person, even it's more important to fit yourself on the real priorities and needs of this type of patients. And that's the reason why I think we have learned a lot about them. The frailty scales are ones that included this type of things. So I think the issue, the challenge, is to use that everywhere, because I have no doubt that the geriatric patients probably are the ones that are receiving more of this type of care, also palliative care. But what about in acute care? Do we have time to be a little bit included what is needed, not only for the clinical self-management, but also for the emotional self-management of the conditions? I remember a patient with a stroke, and they were saying, well, when you arrive to the hospital, they'll save your life, and then they leave you alone. So it was so clear what was happening. No, there was, I mean, the acute part, fortunately, in that patient was solved, but then he or she was needed to address every part of the care that was not taken care by the hospital. Logotherapy, rehabilitation, coordination, blah, blah, blah. So I think it's important to think about our patients and be sure that we make this approach, because at the end, probably it's worth to do that and even cost effective.
Any questions from the audience? Don't be shy. Yeah?
Thank you very much for sharing your experience. This is Jihan Alfanem from Oman. So definitely self-management interventions moves the power from the healthcare providers and gives more power to the patients. Because maybe over the last 200 years, we hijacked it as healthcare providers. And I think that is one of the ways that, we can start to really invest in this. My question for you is, do we start with the simple diseases, the complex ones? What should be the priority? Should we start in multiple areas or just focus in one area? Thank you.
Yes, I think this is a very important. Can you hear me? It's a very important question, and this is also about contextual factors. I think it's important maybe to have in mind what are your contexts, what the patient context, because when linked with the previous comment on frailty, it's important to consider what is the burden for the patient, what are the significance of this decision for the patient and for the healthcare professional. So I think the importance of establishing these priorities involving patients and healthcare professionals is the first step. So you should decide on the priorities. Not necessarily this means to start for the acute disease, maybe start with a chronic condition that are patients that are more needed in terms of the self-management, but maybe prioritize, considering your resources, what kind of patient, also considering the results. For example, if you have some patients that have more readmissions, patients that have a high healthcare use, this kind of ways to prioritize, but always involving patients. I just suggest that.
Actually, if I can just add to that, I'm happy that you picked up the data component, because I think there's definitely a change in the power relationship, but in order to identify a starting point, I would also suggest a data-driven approach. If you work in a health system and you can look at readmission data or other type of data that suggest there might be an opportunity to improve outcomes, but also perhaps prevent inappropriate hospitalization, then this would be an excellent opportunity. And then if you can bring together providers and patients to identify how best to embed the plan for the intervention that you have in your local system, then I think you're building a good foundation for success. Here in the front, please.
Can you hear me? I'm Quality Director of German Hospital Cairo. I have a comment and I have a question as well. The comment is patient-centered care, of course, one of the most important issues and topics, and it's also very changing dramatically. It's moving forward. Now we are talking about person-centered care, and after that we are talking about patient experience as well. Of course, this study is very important, and of course I am with the study. I will ask the questions, but please don't consider it as attacking for what you are presenting here. But honestly, I want to understand what is the aim or the result of the study? Are you want to prove that patient-centered care, including self-management intervention as a component, or you are just want to direct the whole patient-centered care to this direction? So, because as I said, patient-centered care started with patient-centered care, then moving to person-centered care, moving now to patient experience. We don't know what's next. So, you are emphasizing on making it self-management interventions, or you are emphasizing it as a component for patient-centered care as a whole process? Thank you.
Thank you very much. I think it's a very important question to clarify. As Professor Sunyol described in the first part of this session, when we talk about patient-centered care, we talk about different components and elements. Of course, patient empowerment is one of these. And this Compare EU project was just focused on self-management intervention. And we thought that bringing this output, because it's an ongoing project, that the main objective is identify what are the most promising intervention to improve self-management intervention in some chronic diseases. But we thought that was important because maybe the less developed in the hospital environment, because of course patient-centered care involve other areas as humanization of care, improving patient experience, and of course improving patient empowerment. So the answer would be is one component of patient-centered care.
I think, Marta, you wanted to add to that?
Yeah. I just wanted to chip in that also we have to be humble. I think all of us here, we believe that self-management interventions can be very useful in making better results for the patient and the professionals. But we might also very well find that some of the interventions are not improving this. And our hope is also that we will help clarify this very big and now, as you say, ever-changing field into something more specific, and we can direct the efforts of other stakeholders into those that are more effective, relevant to patients, and cost-effective as well for the system. So not everything that's labeled self-management and patient-centered care is actually that useful for the system, of course. And I have a question online, maybe? Shall I?
Go ahead.
I will say, again, more a comment than a question, but I think it's very relevant. Someone anonymously also said that they would like to underline the satisfaction of the professionals who practice patient-centered care or person-centered care.
Yeah. Well, yeah. When I first entered this field, I'm a pulmonologist by training, and I had patients for COPD and asthma for a long time. And I said, well, this is what good professionals have done all their life. to train patients to avoid readmissions, to avoid exacerbations, no? But I think the difference is that it's not trying to expect that the good professionals do that. We expect the system to do that, meaning professionals, all the professionals in all the specialties trying to improve this change of paradigm. So I think, yes, I agree, but I think it's an issue that it's to work for all of us.
Further questions from the audience?
So effective discharge planning or end of service planning will benefit such intervention?
I'm not sure.
Can you say that again, please?
I'm sorry. Effective discharge planning.
Yeah.
End of service planning.
Yeah.
Yeah.
Which is early to the admission.
Yeah.
Will benefit such intervention?
Yeah, for sure. This is one of the interventions that were included, for example, for heart failure, that there are several randomized control trials evaluating if early discharge planning involving, of course, all these elements that we have reviewed are effective or not. And this could be an example, how we plan the patient, how we prepare patient, better prepare patient to be at home or in other services.
I think it's very common in many countries that we are discharging patients from the hospital and they don't know how to take the drug, they don't know what the symptoms look for, they don't know when to see the next doctor, and there's no information transfer. And all these are elements that are very relevant to the early discharge planning. So it's a good comment. Thank you.
Why is it changed from patient to person? Because they are involving the family as well and the care for the patient, because not only the patient is the one who care for himself.
Yeah.
Also care must be identified and of course have the same education like the patient.
Absolutely, absolutely.
Agree. Marta.
If there's no questions, I wanted to pick up on a mention that you put in your question about this transfer of power, which I think is totally right, that they have maybe too much medicalized and we need to give back part of that power to the patient and recognize that they are an active agent. But I think it's also very useful to think about power in a different way. And I think for those of you that were today in the Women in Leadership and New Leadership plenary session, they actually mentioned the topic like we have to change our conception of power and not focus only the power of you over me or me over you, but also our joint power to achieve something together. In the end, we should all be working to shared outcomes, right? We want to improve the quality of life for our patients. We want to improve the clinical outcomes. They want the same. And we believe that if we do self-management, we can have more power together to achieve this shared outcome. And I think that's a useful mindset when we think about this sort of intervention.
Any further questions? Okay. Maybe then no further questions, maybe Carola, you want to offer some sort of closing remarks?
Just kind of some conclusions from this session that we hope you share and inspired to implement some self-management intervention or other intervention to improve patient-centered care. We think the first objective was to make aware or be aware that the importance of listening patients and carers, including them in the process, look for their priorities and better experience. Not always their priorities are aligned with our priorities, and sometimes they are competing priorities, so it's very important listening them. And I like to include this, nothing for us without us. So this is the first I would say, conclusion from this session, involving patient and stakeholders to define which are the main outcomes, because we have the tendency, in general, in quality improvement, to define and decide what we want to improve, what we want to achieve. We want to reduce adverse events. We want to improve effectiveness. Okay, but what are the patient priorities? Also on this area. So define what are the main outcomes and objectives to achieve and considering these competing interests. And then the importance of implementing self-management intervention, again, as any complex intervention, any quality improvement intervention, and increasing patient empowerment is important using a guided and a structured process to avoid loss of efficiency, to avoid any improvisation while we are improving the process of care, because any effort we do is also a resource that we are spending. And it's important considering all relevant components that are quite obvious, but not always are considered, and also these contextual factors. Because even when we talk about frailty, we talk about patients with multiple medication, with a high burden, then we expect them to self-manage their disease, and maybe they have other priorities. So decide together with the patient which are the most important. And this is also a way to better design this intervention, consider this context. And of course, importance of co-production and the training and preparing patients, and as always, demonstrable leadership from clinicians and managers, and always measuring to improve. So if we want to improve, we need to measure not always clinical outcomes, also some intermediate outcomes, sometimes some intermediate outcomes, including how patients are improving their empowerment. So that's it, and I hope this was a helpful session, and we are open to be contact or to keep the contact, and also you can find all these materials in our web from CompereU and of course in the Congress website. So that's it, and I don't know, you're starting. Okay. So maybe I can stay here, because now we can pass to the next session. Okay. So maybe. So the next session that we have organized for today is about patient safety in perioperative care. I hope you also consider as a very interesting session. This is provided by Dr. Daniel Arnal. He is an anesthesiologist at the Hospital Universitario Fundación Alcorcón in Spain, and he is a European Society of Anesthesiology and Intensive Care Patient Safety and Quality Committee Chair. So the responsible of patient safety in the ISAIC, that is a European Society of Anesthesiology. Dr. Arnal is also co-founder and immediate past president of the Spanish Anesthesia Incident Reporting System, SAR, and is vice president of the Quality, Patient Safety and Ethics of the Spanish Society of Anesthesiology and Reanimation, CEDAR. And he has a lot of publications and scientific interest on patient safety. And today he is going to present a joint initiative we have been working together on accreditation model for excellence in perioperative safety. Go ahead, Dr. Arnal.
Good afternoon, good evening. Thank you everybody for staying with us in this during this coffee time. It's a pleasure to be here. I guess that we are skipping coffee, we might have a better sleep tonight, so that is good for us. I am Daniel Arnal. I am anesthesiologist, and I am a clinician working in the Fundación Alcorcón University Hospital in Madrid, Spain. And for this topic, I don't have real conflict of interest apart from the positions that very kindly Carola has shared with you. And I also would like to express my gratitude for being invited here by the Fundación Avedis Donabedian and the Congress organization. Also, I would like to share with you, not a conflict of interest, but actually an acknowledge of this project that has been funded thanks to non-restricted grants by Medtronic, and has been a very important partner for what we are doing. This is the expert excellence in patient safety perioperative, which is a model for accreditation that we started working, and we've been joining with 3 partners, especially Fundación Avedis Donabedian and Sensar. Fundación Avedis Donabedian has been presented before, and its background is very well known, more than 30 years of working in excellence and health and social care, and it's been awarded many times. So it's a pleasure to work with these partners. And about Sensar, well, it started in 1999, just before To Err is Human publication. We started in a small hospital where I actually work, the Hospital Universitario Fundación Alcorcón, a departmental anesthesia and intensive care incident reporting system, trying to learn from errors. And this experience was then expanded into different hospitals, reaching 120 hospitals in Spain, Chile, and Uruguay, that we share a common database, shared local analysis, and shared local improvement measures, where every hospital is using the incident reporting to improve perioperative care. To date, we have registered more than 20,000 local improvement actions, thanks to all the incidents related to patient safety in the different hospitals. So we thought that there was a lot of effort and an interest from the professionals to really improve patient safety in the perioperative period, but sometimes we lack of a common framework to work together and say, okay, let's go, and these are the basics that we have to work on. So we have in Sensar different activities. The main part is centered is learning from incidents. That's okay, but we also spread knowledge on patient safety culture. We have quite important educational programs in safety. We do a lot of networking with other scientific societies, patient associations, and industry partners. And we have also innovation activities. And one of these innovation activities workshops, we started working on different topics. One of them came up to be about how to bring all this together and try to celebrate when a hospital, a team, a surgical team is actually improving patient safety. So we started working using design thinking techniques, going into interviews with healthcare professionals, all type of healthcare professionals in the surgical field, doctors, nurses, assistants, even operators and middle supervisors and so on, to see what were their needs, their pains, or their gains, and we worked all this, and we came upon the need of developing an evaluation and improvement model centered on the surgical patient safety practical strategies, not just very top-down level quality approach, but more on what is really relevant for the patients. So the objective was clearer to go for good practices selection, how to measure and evaluate them, which is quite difficult, as you might imagine, then piloting and managing a platform, a proposal itself. We worked out a methodology following previous publications with its justification, focused on the perioperative patient. We did the planification with processes and timelines that we have been managed to, even throughout the pandemic, we've been coping with the deadlines and always going through evidence and expert recommendations, bringing together a lot of stakeholders that you will see later on for their recommendations and participation, and trying always to have an being very cautious about wording and accessibility of the work we are doing, and then piloting to really work out and change what we were working in a cycle way. So these have been all the partners that we've included. These are different Spanish scientific societies, surgeons, nurses, the Ministry of Health, intensivists, anesthetists, even hospital managers, but not only that, also patient organizations that are linked to surgical care, which is not easy to find because, as you know, many of the chronic disease do tendency to associate, but not the surgical patient, which is usually acute, and then after going through the surgery, they tend to try to forget about it and don't usually associate. But we did find with the Crohn's disease Spanish Association, they are very much interested in improving the surgical outcome. And then we had kind of three different levels of implications in the work, and we started in a preliminary stage by focusing what are we going to include in here, then working on a criteria first draft, then a Delphi survey with the rest of the partners, piloting, and the definitive criteria model. This was the first phase, and this was already accomplished at the end of last year. So we decided to go for the whole perioperative period since the surgical consultation to the hospital discharge. Of course, we could go even farther, but in terms of feasibility of the that we wanted to be sure to be to reach, we stopped there. We did include elective and emergent surgical procedures, but we had to leave out, unfortunately, pediatric patients, obstetric patients, and out-of-theater procedures. That would be for a second phase of the project, probably. And we started working on the different areas with the implication of the surgeons and of the different organizations, anesthesiologists, surgeons, intensivists, nurses, and all working together to work on the different drafts. And we found 13 thematic areas, initially with quite a few criteria. Then we developed the Delphi digital platform. We recruited the expert panel. At the end, we worked out the Delphi with 28 experts in 2 rounds of 15 different stakeholders, and with 71% of response, we went into having 148 patient safety criteria, and then we did a piloting of how this would work in real life in 2 very different hospitals. Hospital de la Fe of Valencia in Spain is a tertiary university hospital, huge, over 1,000 beds and a large surgical workload. and it's a public hospital. And also we did it in a medium-sized private hospital in Madrid, which is also very hard on surgical activity, but a different environment. And in both of the two situations, it worked very well with hospital preparation of local contacts, a structural survey, and then all the documentation that was needed. And we performed an audit readiness and then a presential audit in both of the hospitals. And we did have very good comments in return. It was very much appreciated, which was not that surprising because since the very beginning, what we were working on were on the design thinking, where we started working on the first line providers to see what were their needs. And with that in mind, we worked out, and when we worked out in the piloting, we had very nice comments. And also we had the opportunity to do some modifications in the writing of specifications, in the sources of evidence, or even redrawing some of the criteria, which at the end came down to 170 and 47 patient safety criteria. So the value of this project is that has a very important clinical focus, which is also important that it would be evaluated by peers. It is evaluated by peers. We are clinicians that are helping our peers to improve their safety structures. It will be focused on the perioperative period, which is a source of problems for patient safety, very important because of the complexity of all the perioperative procedure and the vulnerability of the patients during that period. It will be a system that will be available nationally, and it could even be available elsewhere. And it will integrate in that network of 120 hospitals that are working already in Sensar in patient safety. So that's also a gain and a value in comparison with other potential accreditation systems. And now we are working on the next step, which is actually the implementation plan. So we are working on preparing all the documentation needed for training for the auto evaluations, which will be the first step through the training, through the it will be performed an improvement proposal and some mentoring, and also working on how will it be actually be accredited this effort for patient safety with all the rules and procedures needed, preparing the committees and the management platform, and then also the auditors training. All the materials are nowadays being written in the first draft, always having in mind the initial part. What were the needs from our colleagues, first-line healthcare professionals, doctors, nurses, and the rest of colleagues that are working for patients, and they were kind of needing a way to acknowledge their effort and a guidance to really work from down to top more than just top-down or practices. And that's it. Thank you very much. I believe I'm finishing time. I wanted to share all the effort that we are working. This is work in process, and hopefully very soon we'll be able to provide more about this to all of you. Thank you. If there is any question, I'm very happy to answer.
For now, there are no questions on the online app. So it will be for our people here presenting, if you have any questions.
Okay, I like silence. No worries.
Daniel, maybe we can explain a bit about the content of this accreditation system in terms of what kind of topics you are more specifically evaluating.
Yes. Well, going back to I believe here, the thematic areas that we have been working on them. As you can see, it goes from the perioperative evaluation and patient information. Much of what we've been talking about, patient empowerment, and that we've been talking, but also with a strong part of preventing complications. Actually, one of the topics that has more criteria, which is more important in the whole process, is number 5, patient support and complication preventions, and number 6, to standardize some operation procedures to be sure that some of them are, these key procedures are well implemented as updated and so on. But it goes from the perioperative evaluation to strategies to use properly medication, safe medications use, which is very important in the perioperative patients because we are using very strong and dangerous medications such as opioids and some others. Healthcare, infection prevention, safe equipment setup, that is very important when we are talking about anesthesia, and we're working on some anesthesia machines, and not only anesthesia machines, but these machines that where patients' life is relying on them, and always as well as say as human resources, which at the end it's also key to organize a safe, is kind of the basis. The more we are talking about safety, the more we talk about safety too, which is, okay, how professionals manage to organize the complexity and the skills that we are working in the day-to-day care. That is also very important. And finally, a final topic which is also important is the safety evaluation, which we usually lack as part of many of our hospitals that we really believe should improve to really measure what we're doing, to really be able to show some improvement, at least in procedures and then finally in outcomes.
Thank you very much.
Okay, yep.
When we are trying to implement the project, we are enthusiastic, but when it comes rolling, we come across some barriers. Which were the most important barriers in your case?
In our pilot test that we performed, the most important barriers were the different managing or focusing for different information system from the different hospitals. It was very difficult. Some hospitals were easier and others were very difficult to really get the information. So many of the changes that we had to perform in the criteria were about the sources of the information to get that information, which were in many cases was not automatically being downloaded, and we had to go on face-to-face conversation in focal groups, in groups to really get a good overview of how things have been doing in these hospitals. So getting the information is very difficult, especially if you try to do it in a cheap way, which would be quite automatically. That is, unfortunately, it will be quite difficult to achieve. And so we've been working out how to do it feasibility in a feasible way, but getting the best information we can. But that will be the main barrier right now that we foresee and that we've seen in the piloting. Good. So maybe we still have 1 minute for a coffee. Thank you so much for your attention.